Hi, my name is Bitna. I'm a professor at the Department of Criminology and Criminal Justice at the Indiana University of Pennsylvania, United States. This presentation was prepared with my colleague, Dr. Chung-Hyun Seo. This presentation will focus on our research on police response models for handling people with mental illness. More specifically, I will explain how the police responded to the mentally ill and whether the police response was effective in the United States and other countries. I just Googled for content related to mental health during the COVID-19 pandemic, and I saw a lot of news stories that police received more and more mental health calls. As you can see in this slide, it happened in the United States, Canada, and the UK, and many other countries. Although the number of people with mental illness increased after COVID-19, it is important to note that mental health problems were already serious before the pandemic began. This slide shows the global statistics before COVID-19. In 2018, about 14% of world population suffer from some degree of mental illness. Statistics from each country also show that mental health issue is national concern. As the number of people with mental illness increase, so does the chance for police to deal with people with mental illness. In the past few years, we can easily see the mass media discussing police excessive and inappropriate response to people with mental illness. Academic articles also show that police response is limited. Usually people with mental illness are arrested or imprisoned. In addition, police are more likely to shoot or kill people with mental illness compared to others without mental illness. In order to effectively better deal with the situation involving people with mental illness, police begin to implement response models. There are several police response models. Some models are more popular in certain countries. Today, I introduce two popular police response models. The first example is the CIT, Crisis Intervention Team. The CIT was created in 1987 in Memphis, Tennessee, after Joe Robinson, who had mental health and substance abuse issue, was shot and killed by police. CIT is 40-hour training for police officers. Police officers who received this CIT training responded to people with mental illness whenever necessary. According to the recent statistics, about 20 to 25% of frontline officers in 15 to 20% of U.S. police agencies participate in this training. There are no exact numbers, but other countries also operate this CIT training. Another example of the police response model is PACER, Police Ambulance Clinical Early Response in Australia. Unlike a CIT model, under PACER, police collaborate with mental health professionals at the scene involving people with mental illness. As I just presented, there are several police response models around the world. These models can be categorized into two groups. One is the group in which the police are trained and responsible for handling the situation. The CIT is included in this group. Another group is police response models, in which police work with the mental health agency. PACER is included in this group. Regardless of the type of police response model, PRM, police response model, has 4 main goals. That is, improving police officer attitude toward the mentally ill, knowledge of mental illness, and de-escalation skills. And the most important goal is to reduce arrest, increase the divergence strategy, while keeping officer and mentally ill people safe. To evaluate the effectiveness of police response model, I and our research team synthesized the previous research on this topic using meta-analysis. This study has been just published in the International Criminal Justice Review. Today, I would like to introduce the main finding of the study. As seen in the plot chart, using a systematic review approach, we found 42 studies on the effectiveness of police response models. In this meta-analysis, we focus on 2 research questions. The first is estimate if overall mean effect size, and the second is whether the effect size varies depending on the country of study, PRM type, or research design. QuantD is used as an estimate of effect size. The overall mean effect size is calculated using random effect models. Moderator effects are tested in subgroup analysis with Q statistic for the homogeneity test. Of the 42 studies included in this meta-analysis, 30 studies are about PRM in the United States. And this meta-analysis includes 12 primary studies outside the United States. As can be seen in the table in this slide, an estimated effect size QuantD was calculated for each outcome measures in each study. Effect size estimates from primary study weighted and combined, and then overall mean effect size of PRM was estimated using a random effect model. The first plot in this slide shows that the overall weighted mean effect size of 42 study is 0.49. This meets a moderate effect size using a Quant's benchmark. The table in this slide shows PRM has different effects depending on outcome measures. That says while PRM has a significant impact on police officer attitude, knowledge of mental illness, PRM does not improve safety of police officers and people with mental illness, does not increase divergence strategy rather than arrest. However, the limitation of our meta-analysis should be noted. That said, the effect size of arrest, usual force, response time, and injury estimate based on few studies. For example, outside the United States, there is no research on the impact of PRM on arrest, use of force, and injury. The first analysis found that PRM has moderate overall effect and strong influence police officers' attitude and knowledge. The moderator analysis was conducted to investigate the impact of location and PRM type and research design on effect size. The table in this slide shows larger effect size in studies outside the United States. PRM was most effective in Africa, followed by Australia, UK, and U.S.A. and Canada. There was no significant difference in effect size in terms of PRM type. That says all CIT, co-response models, and other models have a moderate effect. Although not statistically significant, the study using the experimental design show larger effect size. This is good news. we can have more confidence in the positive impact of PRM. Based on result of the current meta-analysis, we can conclude that police response model is evidence-based police strategy to effectively handle people with mental illness across country, especially outside the United States. However, due to the lack of research on this topic, our synthesis result must be interpreted carefully. More attention should be paid to different types of PRM, including co-response models outside the US and models with short training time in the US. Objective outcome, including the safety of police officers and mentally ill people, and the use of divergent strategy. Our meta-analysis concludes that national context matter in the effectiveness of PRM. That said, it is more effective in outside the United States. However, our research cannot explain which national or cultural contexts matter. It could be people's general perception of people with mental illness, a partnership between police and mental health agency, or police culture. Future comparative study should answer this question. Thank you.